Hello, and welcome to Pri-Med's podcast on severe hypoglycemia. We welcome Dr. Diana Isaacs, an endocrine clinical pharmacy specialist and CGM program coordinator at the Cleveland Clinic Diabetes Center in Cleveland, Ohio. She has been on the Speakers Bureau of Dexcom Incorporated, LifeScan, Novo Nordisk Incorporated, and Xeris Pharmaceuticals Incorporated in the past 12 months. The learning objectives of this podcast are 1. Compare and contrast current available pharmacologic options for the treatment of severe hypoglycemia, and 2. Facilitate shared decision-making, SDM, for diabetes patients and parents and caregivers regarding the selection of therapies for the treatment of severe hypoglycemia. Before we get started, let me remind everyone that this podcast is supported by an independent educational grant from Xeris Pharmaceuticals Incorporated. For more information, please visit the activity page for this podcast on www.pri-med.com. Thank you for joining us today, Dr. Isaacs.
Hi, it's great to be here today.
We'd like to begin with our first question. What would you consider to be a hypoglycemic emergency, and what are some of the signs and symptoms?
Well, first of all, I think it's a good idea to just review general hypoglycemia, which can be split into 3 levels, level 1 through 3. Level 1 is considered a glucose that's below 70 but over 54. And at this point, typical symptoms generally include things like shaking, sweating, hunger, a rapid heartbeat. Now, level 2 hypoglycemia is when glucose goes below 54. At this point, the symptoms include things like behavioral changes, where a person is acting differently, confusion, blurred vision, even seizure and loss of consciousness. And it may be difficult for a person to even realize that they're experiencing hypoglycemia. Level 3 is considered to be severe hypoglycemia. And at this level, it's actually not defined by a specific number, although as you might imagine, it's more likely that glucose would be in the level 2 range, under 54. At this point, there's altered mental status, and the definition is that it requires assistance from another person. So a person is not able to treat the hypoglycemia by themselves. So it is this level 3 that is considered to be a hypoglycemia emergency. And again, just emphasizing that a person is not able to treat themselves and needs the help of someone else. Otherwise, they are not going to be able to resolve that hypoglycemia.
What types of patients are at the highest risk for a hypoglycemic emergency?
Any person that's taking a medication that can cause hypoglycemia could be at risk. So most commonly, we think of insulin. We know that insulin can cause hypoglycemia. And then there's a couple other medication classes, including sulfonylureas, which are drugs like glipizide, glimepiride, glyburide, and then also less commonly used meglitinides, which includes nateglinide and repeglinide. So all these drugs, through their mechanism of action, can cause hypoglycemia. And then even though the other diabetes classes aren't expected to cause hypoglycemia when used alone, anytime you add those classes to insulin, sulfonylureas, or glitinides, a person can be at risk of hypoglycemia occurring. So this is going to happen. This risk can occur in anyone with type 1 diabetes because we know that they require multiple daily injections of insulin or insulin pump therapy. And then it also can occur in people with type 2 diabetes, especially the ones that are taking multiple daily injections are at the greatest risk. And because, 90 to 95% of cases are actually people with type 2 diabetes, even though hypoglycemia overall may be more common in people with type 1, we're actually seeing a lot of people with type 2 diabetes that could be potentially experiencing the severe hypoglycemia or hypoglycemic emergencies. Now, there's certain factors in addition to just the medications that also can increase a person's risk. This includes things like erratic schedule, where there's not so much consistency with meal times, with sleep schedule. Also things like stress. Stress can definitely lead to erratic glucose readings, which can contribute to hypoglycemic emergencies. Other things like alcohol use, poor cognitive status, and then renal disease have also been implicated. And a note that I would just like to say is that, in patients who are at increased risk for hypoglycemia, it's really important to consider having the patient wear a medic alert bracelet or using a continuous glucose monitor or CGM to be able to identify those declining blood glucose levels early on and hopefully reduce that risk of developing hypoglycemia.
What options are currently available for the treatment of severe hypoglycemia, and what are their differences?
Fortunately, now we have newer options of glucagon, which make glucagon administration a whole lot easier. And really, the number one thing that you're going to want to use for a severe hypoglycemic episode where a person's not able to eat or drink is going to be glucagon. So we have 3 formulations now. There is a nasal, there's a pre-mixed stable liquid, and then there's also a lyophilized glucagon powder injection. Now, some of the differences with these include the nasal is obviously it's administered in the nose. The stable liquid is a ready-to-use formulation. It is currently available as a pre-filled syringe, and it's expected in July 2020 to also have an auto-inject option. Now, the glucagon powder requires reconstitution before use. So it is a bit more cumbersome to use. And this is the product that we've had, for decades. And so it comes as a vial with a powder, and then it comes with a syringe that has liquid in it. And you need to take that liquid and put it into the vial, and then you need to mix it. So you're reconstituting it. And then the person needs to actually draw it out with that syringe and then get ready to inject the person with the product. So as you can imagine, for people that are not trained healthcare professionals or even those that are trained, this can be quite a cumbersome process to do during an emergency situation. So fortunately now, the nasal glucagon is very simple to administer. It is delivered in the nose, and it is, it's a button press into the nose. And the pre-filled syringe is also, it's ready to make. You take off the cap and you inject it. So it's a much simpler process compared to what we've had for so long. Now, there's some other differences between the products that are useful to know. And so one is the age-approved indications. So the nasal glucagon is approved for ages 4 and over. The liquid stable glucagon is approved for ages 2 and over. And then the glucagon powder is actually approved for any age. Some other differences to note are the site of administration, right? So the nasal is obviously going to be administered in the nose. The pre-filled liquid, it's delivered subcutaneously, and the sites are really the same sites where a person could administer insulin. So the lower abdomen, the outer thigh, or the outer upper arm. And this is different from the glucagon powder, which can be administered subcutaneously, intramuscular, or even IV. And it's actually a bigger needle, and can go in the upper arms, the thighs, or the buttocks. So not the abdomen in that case. Other key differences, the dose itself. The nasal is actually a higher dose. It's a 3 milligram, and there's no difference for pediatrics versus adults. It is just one dose. The liquid stable glucagon comes in a 0.5 or a 1 milligram. And so if a person is both under 12 and under 45 kilograms, they're going to use that lower 0.5 milligram dose versus if the person is either over 12 or over 45 kilograms, they're going to use that larger dose. And the glucagon powder is similar in that it also has a 0.5 or a 1 milligram dose, and you're going to use different doses depending on the weight and the age of the person. There are slight differences in the kinetics, very, very slight differences in things like half-life and absorption, but really for all intents and purposes, they're all similar in that they're expected to work within 15 minutes. And if they don't work in 15 minutes, it is always an option to give a second injection. One key thing to think about though is with that glucagon powder, it takes a lot of prep time, right? Depending how, efficient you are, it could take a person 2 or 3 minutes. And then there tends to be more errors with administration with that product. So that's something to keep in mind, that would obviously add to additional time if you're doing that. And then another thing is just the adverse effect profile. So glucagon, very similar between formulations. We do expect some level of nausea, which could potentially lead to vomiting. With the injectable forms, it's possible to have, redness or an injection site reaction. And then with the nasal form, the big difference is there could be potentially some upper respiratory infection or nasal discomfort could occur.
When deciding on what treatment option to provide to the patient and/or caregiver, what are some considerations?
Yeah, this is a great question. So I think, just looking at some of the differences between products, if what the person's preference is on route of administration, if they would prefer something in their nose versus something that is injectable. And this will be very patient specific because, many people are used to injectable medications, using insulin. So that could be a preference, but then, depending on what the caregiver's preference is, because usually it's not going to be the person administering it to themselves. Usually it's going to be some type of caregiver, friend, acquaintance, family member. And so what is their comfort with? Do they comfortable with an injectable or do they prefer a nasal type of formulation? And then I think, the age of the patient is obviously going to be a consideration because when we look at the FDA approved ages, knowing that the nasal is 4 and over and that the liquid stable is 2 and over, versus the, powder is all ages, that can be a consideration as well. And then of course, cost and what's covered on formulary, it definitely can be a consideration. Fortunately, most, insurance plans are really expanding coverage to include the newer formulations. So hopefully that will be less of an issue for people moving forward. And there's also copay cards as well that can reduce the prices for people with commercial insurance.
Since patients and caregivers are the ones typically administering the therapy for persons with severe hypoglycemia, how do you include them in the decision process for treatment selection?
This is a great question. So first, I describe the symptoms of hypoglycemia, and I want them to understand, why it's important to be able to recognize these symptoms. And I should really preface that with, I ask first, have you ever experienced a low blood sugar and how did you feel? And try to build off of what the person has already experienced. Now, next, I like to describe all the different options, and I like to go through each, kind of like how we just discussed, how there's different dosing, how there can be different routes of administration, and how it's administered.